Going back to the importance of BTK inhibition in B-cell lymphoma, it seems to be not only relevant to indolent B-cell lymphoma, but also to aggressive B-cell lymphoma, and particularly to the non-GCB subtype, which is a very special genetic subtype of large B-cell lymphoma, where the B-cell receptor is hyperactivated and where BTK inhibitors such as Acalabrutinib have shown some activity. We previously performed a phase 1 study of single-agent Acala, large B-cell lymphoma, but as a single agent in this very aggressive entity, as opposed to indolent B-cell lymphoma, the activity was limited. So in this study, we're actually trying to combine it with a CDK9 inhibitor, which is called AZD4573, which is given intravenously. Of interest, this same agent has already been investigated previously in a phase 1 trial in Europe as a single agent or in combination with rituximab, and the activity in terms of induction of apoptosis was so marked that there were a lot of cases of tumor lysis syndrome. So in this study, we gave a lower dose. We used lower dose levels when combined with Acala. Also, there's some biological rationale showing that by combining Acalabrutinib to AZD4573, the pro-apoptotic activity induced by AZD4573 may be increased, and so overall the combination may be synergistic. As a matter of fact, in this phase 1 study, and ASH, we're presenting the results of the escalation phase, but we're now almost completing the expansion phase, are quite impressive. Even in patients with aggressive B-cell lymphoma who previously received chemo, stem cell transplant, or CAR-T, the response rate was close to 70%, with 30 to 50% of patients have a complete response. And what I need to emphasize one more time is that these included patients who had received CAR-T previously. Now, patients with large B-cell lymphoma who relapse after CAR-T currently have no standard treatment available, and if we do use products approved by the FDA, such as tafasitamab, loncastuximab, polatuzumab, or selinexor, usually the progression-free survival is in the order of weeks or months. So there's really a high unmet need of identifying new agents for these patients. There are some translational data showing that the apoptotic pathway may drive resistance to CAR-T, and I think that's why probably we see this very impressive activity with AZD4573 in these patients when combined with Acala. The limitations in terms of toxicity of this regimen is that due to on-target effect of CDK9 inhibition, we do see a significant amount of myelosuppression. However, this can be managed hopefully in the future by changing the schedule. Of interest, we also see LFT elevation, but this doesn't seem to be a liver injury type of phenomenon, but just a transcriptional event due to the fact that CDK9 inhibition can downregulate expression and transcription of factors relevant to the transport of ALT and AST to the surface channels of liver cells. One last thing that has emerged from this study is that patients with T-cell rich histiocyte large B-cell lymphoma, they all had phenomenal responses to this combination. This is also a high unmet need. T-cell rich histiocyte large B-cell lymphoma is a very rare subtype of large B-cell lymphoma, but it tends to be chemo refractory, transplant refractory, and recent data show that it's even CAR-T refractory. So the fact that we do see this activity signal is very promising, and hopefully in the future we will be able, changing the schedule, to be able to focus on patients with T-cell rich histiocyte large B-cell lymphoma or those with large B-cell lymphoma who relapse after CAR-T.